All right, let's dive in. Today, we are tackling a core nursing responsibility, one where a single number can spell the difference between stable and crisis. We're talking about urinary safety. And trust me, this is about so much more than just comfort. It's a direct window into your patient's blood flow, their risk for infection, and frankly, their survival. So let's break down what you absolutely have to know. So here's our game plan. We're going to start with the single most critical number in all of patient assessment. Then, we'll jump into two major crisis scenarios, what to do when urine flow stops and what to do when it leaks. From there, we'll build up our defenses against infection, and we'll wrap it all up with a high-yield synthesis to get you totally ready for your exams.
Okay, first things first. Let's talk about urinary output as the body's fuel gauge. Before you can fix any problem, you have to be able to spot it. And when it comes to the kidneys, your first and most important clue is always going to be one single number.
This is it, 30 milliliters per hour. I really want you to burn this number into your brain. This isn't just some textbook guideline. This is a critical, screaming alarm bell. If your patient's output dips below this, it's an emergency. Full stop.
So why is this one little number such a massive deal? Because it's not really about the urine at all. It's a direct, real-time window into blood flow. See, when the body senses a major crisis, like massive bleeding or a failing heart, it has to make a choice. And it will always choose to sacrifice blood flow to the kidneys in order to keep the brain and the heart alive. That drop below 30 milliliters per hour, that's your earliest warning sign that the body is officially in survival mode and is on a collision course with shock.
So let's build on that. We know what to look for when output drops, but what happens when the flow stops completely? Not because of a blood flow problem, but because something is physically blocking the exit. This is a super common and really dangerous post-surgical emergency.
The solution for this is often something called continuous bladder irrigation, or CBI. The easiest way to think about it is like a constant, gentle washing machine for the inside of the bladder. Its entire job is to keep flushing things out so blood doesn't have a chance to sit still, form a clot, and cause a major blockage.
Okay, let's draw this out. Imagine this is your patient's bladder right after a procedure, like a prostate surgery. The site where they operated is bleeding, just like any other cut would. So you've got this active bleeding happening inside the bladder.
Now, if you just let that blood sit there, well, what does blood do? It clots. And this is what that looks like. You get a solid mass that basically acts like a cork, plugging up the exit. Urine starts backing up, the bladder stretches to a dangerous point, and suddenly you've got a full-blown medical emergency on your hands.
So how do we prevent this from happening? We use a very special tool, the triple lumen catheter. It's got 3 channels for 3 different jobs. One is for the balloon, to hold it in place. The second is the irrigant in port. This is where the sterile fluid constantly flows into the bladder. And the third, the biggest one, is for everything to flow out. The irrigant, the patient's urine, blood, everything.
And this brings us to the golden rule of CBI. This is the one thing you can't forget. The total amount of fluid coming out has to be more than the amount of irrigant you're putting in. Now, why is that? Well, think about it. The outflow isn't just irrigant. It's irrigant plus the patient's own urine. So if you're putting in more than you're getting out, it means something is blocked. The rule is simple. If that happens, you stop the irrigation immediately.
This little matrix here is basically your emergency cheat sheet. If you see bright cherry red drainage with clots, that means there's active bleeding. You remove, increase the irrigation rate to wash it out faster. But if the outflow is less than the inflow, that's a blockage. Your first immediate priority is to stop the irrigation, check for kinks in the tubing, and then get help.
Okay, let's switch gears. We've talked about obstruction, when flow stops. Now let's talk about the exact opposite problem, incontinence, when flow leaks. And this is a bit of a diagnostic puzzle, because figuring out why it's leaking is the key to your whole plan of care.
This table really helps break down that puzzle. First up, you have stress incontinence. Think S for sneeze. Any pressure, coughing, laughing, lifting causes a leak because the pelvic floor muscles are weak. The fix? Kegels. Then you've got urge incontinence. This is that sudden, frantic, I gotta go now feeling. It's from an overactive bladder, and we treat it with bladder retraining. And finally, there's functional incontinence. Here, the plumbing all works fine, but the person can't get to the bathroom in time because of, say, mobility issues. The fix isn't medical, it's practical, like scheduled toilet trips and clearing a path to the bathroom.
And when we say pelvic floor training, it's more than just telling someone to squeeze. This is how you actually teach it.
There are two parts. First, the quick flicks. These are short, fast squeezes that can actually help shut down that gotta-go signal right in the moment. Then, for building long-term strength, you teach sustained contractions, holding for a full 10 seconds, and repeating that throughout the day.
All right, let's move into our next big topic, and this one is all about defense. We're talking about the constant, pervasive threat of infection, specifically catheter-associated urinary tract infections, or CAUTIs. This is a battle you are fighting every single shift.
So why are catheters so incredibly risky? This picture says it all. A catheter is literally a direct highway for bacteria. It lets germs like E. coli completely bypass all the body's natural defenses and march straight into the sterile bladder. And if that infection gets out of control, it can escape into the bloodstream and cause urosepsis, which is absolutely life-threatening.
So how do we fight back? There are a few non-negotiable rules. Rule number 1 is just simple physics. You never, ever, ever hang the drainage bag on a movable bed rail. Why? Because if someone raises that rail, the bag is now higher than the bladder, and gravity will send all that contaminated urine flowing right back into your patient.
Rule number 2. You must protect the closed system at all costs. Think of it like a sterile bubble. That connection between the catheter and the tubing is sealed for a reason. The second you break that seal, pop, the bubble is gone, and you've just invited a flood of germs inside. If you need a sample, you have to use the sterile port. Period.
And rule number 3. You have to secure that catheter. If it's just dangling, every time the patient moves, it slides back and forth. This motion not only causes physical trauma, but it acts like a little piston, literally pulling bacteria from the outside skin right up into the urinary tract. Securing it stops that from happening.
All right, let's bring this all home. This is our exam-ready synthesis. We're going to crystallize the absolute must-know high-yield points that you need for your tests, and more importantly, for keeping your patients safe on the floor.
Here are the big takeaways. For assessment, if output is less than 30 milliliters an hour, it's a perfusion emergency. For incontinence, you match the type to the intervention. Kegels for stress, retraining for urge, and practical help for functional. For CAUTI defense, the bag always stays below the bladder, and you never ever break that closed system. And for CBI safety, if the fluid stops coming out, you stop putting it in. It's that simple.
And I'm going to leave you with this final thought, a real-world gut check. You see a colleague hang a Foley bag on the bed rail right before they take a patient to a test. It's a common mistake. What is your immediate action, and what's the one simple sentence you use to explain why you're intervening? Because that's not just about knowing the facts. That's about being a patient advocate. Think about it.